Good morning, everyone, and thank you very much for joining us today. We appreciate you being here to learn more about developing a CQI plan in a data-driven CCBHC. I am not your usual presenter. My name is Cy Rogers. I was here yesterday, and some of you have met me in other settings, but I will be the facilitator for today's meeting. And basically, for our purposes this morning, that means if you're having any tech issues, feel free to message me directly. If you're having any other concerns, questions, don't hesitate to use that private message function in the chat. Otherwise, we're here together for about an hour today, and Jane King, our subject matter expert, has much knowledge to share with you all. So I'm going to hand it over to Jane and let her take it away while we all get to learn a little bit more this morning. Jane, take it away.
Awesome. Thank you, Sai, for getting us kicked off. And I was kind of glancing through the list of folks. I think most of you were here yesterday. I didn't memorize names or anything, but hopefully we've got folks so we can dive in a bit into more detail today. So yesterday we did a sort of 10,000-foot view review of being data driven, and I'll review a little bit of that at the beginning, and then I'll get us through today. So for those who weren't here yesterday, my name is Jane King. I'm a licensed psychologist. I've been practicing for about 30 years. And I worked for the state of Minnesota on their CCBHC implementation team way back at the beginning of the demo in 2017. And then from there, while there, I established the CCBHC certification. We were in the demo, of course, and then was able to help write the state plan amendment. Then I moved to the National Council, who developed the CCBHC model, and I helped to create the TA centers for both clinic grantees as well as for states to learn how to implement CCBHC. I've also had a bunch of contracts with states and clinics too. And in particular in Kansas, I've worked with a lot of clinics in Kansas and with the state to get this program off the ground. So very excited to be with you guys today. All right, as I said, we're just going to do a quick review of yesterday. So if there's anybody here who wasn't there or who wasn't here yesterday, then we'll get you a little review. And then we're going to dig into the details of it today. Yesterday was an overview, but today I really want to have us work together thinking through how do you use all the elements that I presented to you yesterday to make sure that you are being a data-driven CCBHC. Sorry, wow, a lot of stuttering this morning. I think I need to take a breath. Oh, okay. So we'll follow that cycle of assessment that we learned about yesterday, and then we're going to dive into building a behavioral health system. And then all of this comes into a CQI plan that you develop as you are getting certified. All right. So what is it to be data driven? Yesterday we talked about sort of the pillars of CCBHC, which is that there's an integrated clinical model, which many of you focus on. There's a sustainable funding model, which many of you are thrilled about. And then the quality measurement model is really where we're talking today, is getting into that cycle of understanding what the needs are in your community, first through a community needs assessment. Then from that, you're setting goals as a CCBHC towards we want to increase access to a certain population, or we want to add a whole bunch of treatment slots because we need it, or we've discovered there's a whole population of folks who aren't getting services, so we're going to focus on learning their culture and being able to introduce folks to the environment that feels safe for them. So then from that, understanding the needs, setting your goals, then you start developing your CCBHC program. And right away, or even before you've done the development, you're already thinking about how am I going to measure if I'm reaching the goals that I have set or that we have set for our clinic? How do I know if we're getting there? So you start to come up with quality measurement in order to look at your own goals, but also the federal quality measures that are required as part of the CCBHC program. So you're kind of doing a little bit of both there and reporting it to the state and also reporting internally so that you can learn from it within your continuous quality improvement program or your CQI program. And so as part of certification, you develop a plan, a CQI plan. But then once you're up and running, you're kind of living in a CQI world. You want to be able to be responsive to things that you're finding out about the treatment that you're providing, maybe finding out that there's a group that isn't liking it, or there's a group of folks that aren't getting what they need. And so you're always sort of looking to see, could we have done that better? Could we come up with new evidence-based practices to implement in order to address the issue that we've seen, et cetera? So it's this whole cycle that you're going through of wanting to understand needs, setting goals, measuring whether those goals are working, and then doing quality improvement in order to meet those goals. And I also mentioned yesterday for the clinicians in the room, the concept of the golden thread. Many of you are probably very familiar with this, but as a psychologist, this is what helped me understand being a data-driven organization. I had to sort of bring it down to the clinical level so that I could conceptualize it. And the golden thread is the idea that you get to know somebody and what's going on for them, and then everything you do is based on those needs that were discovered at the very beginning. And then you've got this golden thread pulling you through treatment, letting you know that you're on the right track. So it starts with an initial eval or a comprehensive evaluation or a diagnostic assessment, etc. This is where someone like me is sitting with a person and asking lots of questions, getting a sense of symptoms that are becoming difficult for someone to manage, and then from that, forming a diagnosis. So you've got this report, this diagnosis, you know now what the issues are. The next thing is talking to the person about what are their goals. I want to get a job. I I remember in a training that I went to, there was a person that always gave the example of I have a person I'm serving who wants to be president of the United States. So we started breaking down what all the pieces would be that you'd need to have in place in order to be president. And you could work it all the way back to it would be important for you to be able to ride the bus in order to go to school, to be a lawyer, et cetera, et cetera. So you're figuring out what's going on and getting with the person to help them figure out what do they really want in their life. And then you start to put together, well, okay, what are we going to do to get there? What are some things I can do, interventions that will help you sort of come to these conclusions on your own? What are things that you're going to do? And then I'm evaluating that. Is this working? And, informally in therapy or in some sort of treatment environment, you're constantly evaluating whether this is working. As someone's talking and you say, I wonder XYZ, and they go, no, that's not really what's going on. Then whoops, I went down the wrong path, and you quickly reassess and provide a different intervention, see if that works. If it does, great. If it doesn't, try something different. That's that CQI thing. And so for me, it was helpful to think of the fact that if I'm sitting in a therapy session, I'm doing all these things all the time. It's just happening so fast, I'm not paying as much attention to the fact that I'm following a very clear pattern. So just want to really get this into your minds about how the pattern works and how the cycle works that you're trying to be in. All right, so here's a something that we didn't necessarily talk about yesterday, but I think is so key to all of this. I guess I keep talking about all these foundational elements that are so important, but I don't know if you're like me, but I tend to think sort of big picture. I want to get the whole idea, and then I want to see how it shakes out. So I wanted to make sure you guys got that yesterday. But now we really need to talk about the fact that you could be following that cycle. You could be CQIing all day long, as if that were a verb, but I think I'm going to make it a verb. Um, you could be doing all of this. But if your data isn't quality, it doesn't have high quality, then none of it's going to mean very much, right? So even if I'm in a therapy session with someone and I try an intervention and they go, falls flat, um, I need to be sure that I read that right? Maybe they were just thinking for a minute. Maybe they were not feeling that thing yet, or maybe I picked up on something that they haven't necessarily put right in front of themselves yet. So I might pick up the wrong vibe and then respond to that vibe, and we keep going, and now we're just down a bad path. So the same thing with being a data-driven clinic. It's awesome that you're thinking about community needs assessment and all the evaluation work that you're doing and setting those goals and CQI and all that. It's just not any good if you don't have data that you can rely on. So a key component of doing all of this is making sure that you have strong data that you are collecting in a strong way, and then data that you're reporting on that is accurate. So, some things to think about, and this is all from this framework for data quality by the Federal Committee on Statistical Methodology. Not a job I'm going to have. However, I do know when the data isn't going to help me. So, you can check out this link and see these ideas, but it really talks about that data quality breaks down into three different domains. So, utility, is it useful, right? Is it relevant to what you're doing? If you're wanting to find out if something is working and you use a method to track that, that doesn't even really make sense or doesn't necessarily get at exactly what it is you're trying to know, then it's just not really going to help you. So, under the data being useful or having utility, is also, can folks get access to it? Is it easy to report this change? Are there sort of radio buttons in your EHR? Are there particular things that help people do this so that it can be timely, it can be done punctually, and that it gets down to the specifics that you really need to have in order to measure whether something is working or not. So it has to be useful. The second piece is objectivity. Now, of course, all of the work that we do in behavioral health really ends up being quite subjective because it's about individual needs or community needs. But we need to try to get to as much objectivity as we possibly can. And I think, again, I sort of speak at this from a clinician perspective because I think for me, I understand it. For you, it might make it a little more ground level. But that piece about we are constantly aware of the sort of gray and subjective environment we work in while trying as much as possible to find the objective pieces that help us understand what a person is going through and what their needs might be. So, listening to symptoms and going, the DSM is actually just figuring out that if someone has these symptoms, it's highly likely that they have a particular diagnosis. It's not hard science. You can't do a blood test to test if someone has schizophrenia, but you're using all of these statistics in order to find the similarities across people, and to be able to find those objective measures and those objective ways to look at a subjective world. So I just want to acknowledge that we are trying to pull information in a sort of gray concept, but we're trying to get it as objective as we possibly can so that it's accurate, it can be reliable, and that it makes sense, right? That you look at these numbers and go, oh, yeah, that checks out, rather than, really? That's kind of interesting. All right, the final domain is integrity. And this is the piece that's kind of the extra, right? So we're good at understanding what do we need to know, is it useful to find this out? we're pretty good at figuring out the commonalities, which help us have a more objective perspective. Integrity is that whole nother level of the folks who know how to look at the scientific integrity. They look at statistical practices to see, is this even credible information? Under integrity, the big piece you're thinking about at your clinic level is how strong is your EHR? And I'm sure for those who have been doing this for a while and the folks who are just getting started, without a really strong electronic health record that is able to, I guess, not conceptualize, but process the data to, get people to put it in where it needs to be so it's being collected, but also that it has the capacity to do the reporting that's necessary for CCBHC measures, but also for the measures that you are going after. The other piece that's in there when it comes to collecting data is having processes in your electronic health record that encourage or even require your staff to enter data that must be entered in order to move forward. So you might have pop-up windows or radio buttons, as I mentioned, or ways in which maybe a clinician can't move to the next step unless they do this thing, so that you are collecting as much of the data as you can. Because there's all these points along the way where the data can sort of turn screwy. And so you want to make sure that at every step, you're getting at the right data and the accurate data that's going to make sense for you. All right. So now we talked about this cycle of assessment. So this is just me setting it up for you again. Um, and now I'm going to go into a bit more detail. So yesterday we talked about community needs assessment. So one thing I'm curious about, so today, you're going to recognize some of these slides if you were here yesterday. We're just going to go sort of deeper in, and I'm really hoping that folks can be involved today in just sort of, let's do this work together. Let's figure this out. I imagine there's a bunch of you on this call right now who have done a community needs assessment, have looked at the results of it, have figured out goals and things that you're wanting to do. Um, but I imagine there's some of you out there who are like, I don't know, I'm pretty lost. So, with all of those folks, hopefully we can start to figure out sort of where we are. And I see you popped up size or something that I needed to know. Oh, okay. I was like, uh-oh, I did something wrong. Size already on. That's great. All right. So, and I think you guys are muted, but you can unmute yourselves. Let's just start out here with community needs assessment. So I just want to get some ideas. So again, I'm getting you thinking about your needs assessments that you've done or that you're in the process of doing or thinking about, etc. And let's get some discussion in here because I want to make sure that today in particular, you're getting stuff out of this. Like you're going to go away from this going, oh, okay, now I know how to solve that problem I've been having. Because I want to make sure this is useful to you. So, just putting that out there so you can all take some time to get your ideas together, get your thoughts together, maybe fix your hair, or, so that you look great on camera. But just be thinking about these concepts as I say them, because then I'm really going to be asking you for examples and let me solve some of your problems. So, think about some of the places where you're getting stuck or you're really struggling, bring them here because I'm happy to help you solve it. And maybe in an hour, we can solve a day's worth of issues. That would be awesome. All right. So, yesterday we talked about this, but real quick, under community needs assessment, there's sort of three main buckets of information that you're collecting and that you're going to do things with. So, first of all, who is in your community, who is being served, who is not. So it's really getting to know who lives here. So the demographics of your community. And, sometimes we just think, oh, well, this is just basic information. It's just sort of who and how old are they, what gender, what race, etc. Um, but I want you to be thinking about many of you have been serving the same communities for a very long time, but not necessarily as a CCBHC, but instead as a community mental health center or some other kind of program. Um, and so you're not as sort of up to speed on what's new in your communities. So I think we're going to get into a little more detail in the next slide on this, but in demographics, I want you to be thinking about really who are the folks who are not coming. And that's going to require getting out into the community, doing outreach, and getting to know the folks that are in your community. There may be new populations you're not as familiar with, new languages being spoken. And so this is an opportunity with CCBHC development to sort of pull out and understand how things used to work, but now open your mind to all the ways that it could work in order to increase access or reach goals that you've set. So demographics is not as sort of basic as you think. There's probably a whole group of folks, a whole swath of folks that you don't know, that you haven't been working with, that you haven't engaged with, that really need your help. And the focus of CCBHC is increasing access to care. So it's kind of a moment in time when you can stop and assess what's been happening, assess all the stuff that's happening in your community, the people that are there, and then start to make plans for your CCBHC that address all of those folks. So, again, there might be folks you don't know or folks that haven't been sort of in the forefront, that it's now time to get to know them and find out what it is they need. And that comes to the second bucket, which is service gaps and barriers to access. So it's within this that you're looking at what are your clinic hours? Is that helpful to people who work during the day? Do you need weekend hours? Do you have enough treatment slots for all of the need that is in your community? And you're designing those staffing plans based on that. And then evidence-based practices. Is there a whole swath of folks? I mentioned yesterday that I live in Minneapolis, and so we have a large Somali and East African population. And so we're starting to discover in community mental health and in CCBHCs that there needs to be another way to look at how people are treated who have very severe PTSD. So I was mentioning people, in their 60s who have been living through war their entire lives. That's very different from some of the sort of regular folks or whatever, the folks that have generally been coming to community mental health centers. And so now there might be some evidence-based practices that your clinic really needs to implement in order to address some of those long-term PTSD issues. Maybe it's discovering that you've got a whole group of folks with medical conditions that maybe you're already working with a bunch of people, and as you do care coordination and primary care screening, you're discovering, oh my, there's a lot of medical need in this community. And so maybe we need to be thinking about who we hire to do care coordination. Maybe it's nurses, or which evidence-based practices we start to put into place in order to address those unmet needs. And then you're also all throughout this thinking about partners in your community. And so you're looking at that in your needs assessment. Then, once you know who's here and what's missing, then you look at what's working, right? What does our current data show us that over the last few years we've done this, this, and this that helps us understand what we can do in the future. So, everything you're doing in CCBHC is let's understand what we've done in the past, and now let's dig into new information to understand how we can better serve this community in the future. And that, of course, requires a lot of goals and specific measures for your clinic. And then there's links on the bottom here to check out more information. This TA Center Community Needs Assessment Toolkit is outstanding. I highly recommend using that. And then there are 30-minute on-demand videos available that are me and Renee Boak. And there's one specifically about needs assessment. All right, and we touched on class standards yesterday, but now I want to go a little more into it. So I mentioned in the community needs assessment that you're wanting to uncover populations that have not been coming to your organization. You want to find those places where, gosh, there's just people not getting to what they need. And often it's quite clear that it's based on they walk into your clinic and don't see anything familiar, right? Maybe they don't see anyone that looks like them. They don't hear anyone speaking their language. They don't see signage that is in their language or shows pictures of people being served or whatever that look like them. So it's class standards means it's throughout everything that you're doing, everywhere you go and what you do is thinking about, or I should say, acknowledging and being a part of the cultural and beliefs and practices that are happening in your community. So under class, I love the word bucket. So there are three buckets because I just think it really describes it well. So, first of all, you want to think about the governance of your organization. And where this sort of taps into with a community needs assessment is that you're thinking about, you're getting your leadership to really conceptualize what it is that there are many, many cultures and languages in your community and outside your community. But that you're looking at a leadership level about how to make sure that's integrated into all the work you do. This is also about making sure that everyone who works in your clinic is understanding these things as well. We talk a lot about being trauma informed. And I recently just was speaking to some folks in a brain injury association, and they were talking about being neurologic informed, which I just thought was the coolest concept. That we need to be aware that folks coming in for help, some of them have brain injuries. They may not know they have brain injuries, but we need to go into it knowing that they may say or do some things or have some issues that are sort of relevant to that brain injury. And you need to sort of stop and go, wait, I wonder if that's the brain injury doing that rather than, rage about, etc. So we talk about that with being trauma informed. And so I think this is really about being language and culturally informed, that not jumping to conclusions about what certain things mean, but understanding that it might be a cultural thing. So for example, um, I had a client once back in the early part of my career who she was maybe 9 or 10 years old. And she was living with her grandmother, and her mother had passed away maybe a few years prior, and her mother had very severe schizophrenia. And so as this kid was getting older, it seemed to be that she was exhibiting some symptoms of schizophrenia, but she was so young, it was hard to know. So while I was assessing her, she kept looking behind me. And finally I was like, is there something behind me or someone? And she said, oh, it's my mom. She's here with us. And I was like, oh, wow, that's pretty cool. She goes, yeah, I'm talking to her. She talks to me. And I was like, oh, okay. So then I talked to her grandmother and discovered that in their family, it was a very strong belief that when people pass on, they become ghosts and they stay with you, and help guide you in your life. I could have heard her saying, my mother's standing behind you and she's helping me, as well, you clearly have schizophrenia because that's a hallucination. But instead, I learned a bit about their culture and realized, oh, that is very real to her. So it's not a split from reality for her to think that she is seeing the ghost of her mother. It's actually just part of her cultural heritage and understanding. So we had to take that into account. So it's always sort of stopping and thinking, is that really what I think it is? Or could it be driven by something else that's cultural or language based? Um, so making sure that that's happening at your governance level. So your board should be thinking about class standards and implementing class standards within your organization. And your leadership should be making sure that the workforce is understanding these things too. It's got to be top down. The next piece that I think is sort of the obvious piece that maybe we've all been doing is trying to have signage or documentation or paperwork or um, things that people need to experience in languages that they understand, in described in ways that make sense for their culture. This is where you really get down to sort of the brass tacks of language, of making sure that all of your communication is informed by the cultural groups within your community. And you've discovered that within your needs assessment. And then finally, how do you keep doing that and expanding and improving your ability to work with folks from different cultures and languages is that you're constantly doing outreach and engagement. And one thing that I love about the CCBHC model is that outreach is an allowable expense. So there's really no reason to not be going out to community meetings or religious groups getting together or um, neighborhood meetings. I worked with a clinic in Ohio, and they were really trying to engage the African American population and their community that hadn't really been coming to the clinic. And so they started sending folks to neighborhood block parties, which were a big deal in that area and in that community. So they just started going to these block parties and getting to know people and introducing what the community mental health center does and how they could address needs. And after going to a bunch of these, they realized what people really needed. Families needed play fun things to do. So this clinic started doing a monthly free like kids barbecue and bouncy houses and all sorts of fun things to do for the kids, and they did it once a month absolutely consistently. And so folks that they had met at these block parties started coming to this monthly community play day, and that ended up increasing access to care for a large group of people, all because they sort of went somewhere, figured out what, listened to what people wanted, and then provided it so that it engages people to come in like, oh, if I'm coming to that barbecue fair, well, yeah, you know what? Maybe I will come in and, have you assess my kid because I am a little worried about how he's doing in school or what have you. So there's all these ways to sort of bring it in. Um, and then I'm going to connect that to another concept. What? Oh, I already did that. Sorry, I had a slide for what I just said. But how class standards are part of every step of this cycle, right? You're understanding what's in the community, you're setting some goals from that, you're developing things that are responsive to the needs, and then measuring to see if that works. Population health management is a whole field of work, and it's really about being able to understand the people you're already serving as well as the people you're not serving, to start to see, there seems to be some commonality between folks. And I think a great example is when we all know that people on antipsychotic medication tend to have an increase in diabetes and high blood pressure. And so we really need to keep an eye on those things and help the folks that we serve in a behavioral health setting be aware of those medical issues that will present themselves. And so you're doing primary care screening to check blood pressure and talk to folks about it. The other piece from the data side is you're constantly moving through all the data in your EHR to find those commonalities. Isn't it interesting that we have, I don't know, 100 people who are on antipsychotics, and now that we pull it apart, we see that, oh my gosh, 50 of those 100 have high blood pressure, which we know anxiety plays a role in, as well as diet and medical needs, and medication. And so notice that you have a population that has common needs. So you start to create interventions that address those common needs to see if you can help move the whole group forward. And so really wanting to be able to use those. And that happens in so many different ways. And some examples from clinics are people definitely buy or hire buy hire data analysts and population health analysts. Don't expect your therapist to be able to analyze all the data. Get someone who loves data and knows what they're doing to make sure that, again, that data is useful and that it's getting at where the real needs are. It also helps you develop care pathways, which are then nice ways to be doing CQI. So it's sort of coming up with this is the process a person will go through to get their needs met, and then you can find all the places along that process where you can improve. Integrating with primary care is a great way to address what I was just talking about, and then getting beyond just straight behavioral health and into social determinants of health. All right, so now I'm going to go back to this. And now, as I said, I was going to ask you for some pieces. So I was thinking about what you've been doing for needs assessment. And I think I just want to start with, just out of curiosity, for those who've done some, I want to hear what's something that surprised you. So any of you, you read through, you helped prepare the data for that needs assessment, you read the needs assessment, you were looking through it and thought, wow, it never even occurred to me that XYZ was happening in our community and that there's a need there. So just out of curiosity, folks on here, you can put it in the chat if you want, or feel free to show your beautiful face, Mary. Lovely.
I'm not bringing my beautiful face, but I have this comment to make.
Thank you.
So we need to start working on our community needs assessment. I'm on
Okay.
an organization, it's a healthcare organization. They sent me their China, and I found it very interesting that that particular county has their biggest needs mental health and substance use, and we already have providers, two providers that go to that county. So what that did was help me determine, well, we need to ask different questions when we go to do our needs assessment.
Mm,
Find out what is it that I thought we were providing, but apparently not enough for them. So I think it's important now. I want to reach out to the other counties, look at their needs assessment before we start building ours. So just a
that's That's fa
suggestion.
yeah, that's fantastic, Mary. I love that. And I think it also gets at the state is required to do a needs assessment as part of their CCBHC program. And so I would hope that all of the clinics are deep in that state needs assessment, like, huh, that's interesting. Um, and I love that you then went to the county level. So it's like kind of getting smaller and smaller. You may serve many counties, I'm assuming. And so you got one. So now you're curious about the rest.
Right.
And I love that it wasn't, gee, that shows there's a lot of need, but we have plenty of providers. So, huh,
Right.
everything must be fine.
Yeah.
Well, there's a gap there, right? How is it possible that we have all these slots and people aren't in them? And I think you're really tapping into what's happening, I think kind of nationwide too,
Yeah.
is we're realizing it isn't always about having treatment available, it's about having it accessible, which is really different, right? Is it in a language that makes sense? Is it done in a way that feels like me when I come in to do it? And I think what we've found nationwide is that community mental health centers established to work with the safety net, and they've been around for a very long time, aren't always tapped into sort of new populations coming in or people of color, different languages that haven't necessarily engaged with the system, really. And so the more you feel like part of the system, the inadvertently barriers that you're creating,
Right. And it could be as simple as, we just need to advertise more. Maybe
right?
people don't know we're in that county 2 days a week. So
Right?
we'll drill down and figure out exactly why they have an issue with mental health in that county. So thank
Yeah,
you.
I think that sounds fantastic. And I love that the information popped up and it made you go, huh, you
Yeah,
know? Um,
absolutely.
And that is exactly what a needs assessment is for. And you called it a China, a CNA China.
Yes. At the hospital, that's what we called it as a China community needs.
Interesting. I've never heard that. When you said I looked at their China, I was like, were they pretty dishes or
That's funny. Yeah.
That's awesome. Thank you for that, Mary. That's a great example. Um, and I think she's really bringing in too. And oh, one thing that you said that caught my eye or ear, is there's probably many of you on the call who haven't started yet. So, very exciting that you're just getting started with the needs assessment so that you can hear all this information and realize there is so much we can do in the needs assessment that sets us up for success all the way through our implementation. The more you're thinking about what to understand and how to make it work, the more you can integrate that into your needs assessment and find out. Like we've got to find out if it's needed before we go too far. All
Jane,
right.
I want to call out one thing from the chat here.
Oh, thank you.
Leslie brought in a comment that a community health needs assessment equals the CHNA.
Oh, I was
And
wondering if there was an H somewhere. Thank you, Leslie. Community health needs a set. Oh, you know what? That makes total sense. And so health departments are doing that. Huh.
yeah, county health departments are required to conduct these every 3 years.
Excellent. And community needs assessments as part of CCBHC are supposed to be done every 3 years as well. So that's a nice cycle to be on. But wow, so Mary is letting all of you know if you don't have access to those Chinas in your counties, you are missing something. So hopefully everybody is looking up China right now, and figuring out how they get access to those health needs assessments from county health departments. That's fantastic. And I think it's really interesting too that out of that health needs assessment, you were seeing a need for behavioral health services. I love that that's part of that. Often these health needs assessment that hospitals or medical systems are doing don't always look at mental health or substance use. So that's exciting that within those required Chinas, that you could get access to information about need. And what I hear in there is you're also going to learn quite a bit about the primary care needs of the people in your counties and communities that you're serving. So that can help you think about building your care coordination department. So the more information you get from these needs assessment about where are the gaps and what's needed, then you can go after and fill those gaps, and increase access to care. So all of this from what Mary was saying and me as well is you're doing that needs assessment. Mary has discovered that in this county, there is a great need for services, mental health and substance use services, and yet, we have those. So it makes you wonder, and so you start to think, okay, I bet we can move the needle on these things. So I'm going to go to the next slide and get us thinking. Oh my gosh, there it is. So I have an example for all of you with this sort of process that I've got here. So starting with that needs assessment, maybe one thing you find out in your needs assessment is that there is a higher suicide rate for veterans in your community than there is for civilians. So that's interesting. We find out that currently there has been a small reduction in the suicide rate due to implementation of zero suicide. So, okay, good. We've got some pieces that are working, but finding out that veterans are not necessarily accessing those services at your clinic. So, there's a gap there. Why are veterans not wanting to come to our clinic? And then you're determining, okay, who are we going to focus on? And of those veterans, people with PTSD and major depressive disorder. So then you start to set goals based on that information. So, what are the ways in which we could encourage veterans to come to our clinic? Is it by staffing? Is it by Maybe we need to have evidence-based practices that we haven't done before. Maybe we need to hire folks with experience. Maybe we need veteran peers. So you're sort of doing all this work. We've established there's a gap here. Now we got to find out how could we fill that gap. And then once you have those things in mind of like, okay, I think we can really do this, then you set a very specific SMART goal. We're going to reduce veteran suicide rate in our service area by 20%. So then you're coming up with ways to measure that, right? And so you're going to implement these things like veteran peers or zero suicide, and then you're going to measure whether that's making a difference. So that's sort of building that. I'm going to go a little faster through these because I just wanted you to have this, but notice the yellow box in the upper right-hand corner. If you have not been going to the SAMHSA website about all of the quality measures for CCBHC, then you are so excited because you've been missing out. There's an incredible amount of information there. There's all sorts of webinars that are uploaded, there's slide decks, there's specific policy that will help you look through things, but really dig deep into that quality measure webinar series section of the SAMHSA website because you're just going to see an incredible amount of information and it'll help a great deal. And I love that it's webinars so you can like and slide decks so you could see, oop, I really want to learn about this section and listen to just that. Or you know what? I've listened to this 5 times and it still doesn't make sense. I'm going to go for a sixth, right? But just that opportunity to really understand it. So I highly recommend that you look at that information. And then this is just a list of all of the measures that are required for you as a clinic to collect and report on. And then these are all the measures that the state is required to collect and report on. There are some optional measures as well that I understand were not picked up in Kansas. Most states don't do the optional measures because, this list looks like enough to me. Sorry, I've got something in my eye. But so again, go to these webinar series, learn all about this. This is just so you have in one place the list of the measures. Then this is the establishing that you need to have a CQI plan. So this is now really bringing together all of these concepts into a maintenance sort of focus. So we talked about needs assessment, things that you find out, and then you do some goal setting and setting things up. And then you establish your continuous quality improvement sort of situation. I don't know the best word to use to describe that, but I want to say that I want to say it's an ethos. It is that your organization and all of your staff become very focused on, yeah, but are people getting better? Yeah, but are the services working? Yeah, but are people coming? Yeah, are people getting access to services within a certain number of days or hours in order to get their needs met? It's really, is this all coming together? So this is just straight out of the criteria, what that is. And then again, these are just pieces I pulled out of the criteria. Obviously, you're perfectly capable of reading the criteria yourself, but I thought it might be nice. Sometimes it's nice just to have everything all in one place. So you know that this slide deck will have the information you need going forward and you can refer back to it. All right. So now I want to spend a little time talking about what do we mean by continuous quality improvement? Like it's, CQI, or I'm starting to think of funny words. Chica? I think I'm gonna call it cheeky. Wait, cheeky, chikai. I'm gonna have to think about that one. If you guys have some ideas, put in the chat. But how we do CQI is actually, it seems so elaborate. I remember when I first started learning about it, I was like, oh dear, I'm gonna have to read all these research articles and I don't really understand. And I just kept finding that there's not a whole lot to research on CQI because it's quite simple, actually. You plan, you've done your needs assessment, you figure out your goals, you're putting things into place, you got it all. Okay, cool. Got it in place. Then you do it. You just do it, like Nike says. And while you're doing that, you're testing and you're studying to see Is it working? You've established quality measures that are going to tell you whether it's working. And so you're just studying all along while you're providing this care to figure out, is it working? And these measures, we talk a lot about SMART goals. That is an acronym that I think is quite clever. Um, but I think we all know there's times that we ask ourselves questions about things and then realize, wow, that's such a vague question. I'm not even sure how to answer it. And when it comes to having useful and accurate data, as we were talking about, good quality data, then you have to be asking questions that you can answer, right? So the very specific is when we're talking about the veterans with a higher suicide rate. We want to look specifically at veteran suicide rate. If you look at the overall suicide rate in your community, that's not going to give you the answer that you need for the goal you set just about veterans. So you have a goal that's very specific, and then it's measurable. How would you find out what is the suicide rate for veterans in your community? Um, how would you know it went down? Is it went down by four people or it went down by 20%? Or you're coming up with specific numbers that you're going after so that you can find a way to see if you're getting there, right? I want to get to a 10 and I'm only at a 5. So what do I need to do to cover those last five, right? So very specific and measurable. Attainable meaning, can you even do this? Right? Are you really like I debated putting in the example about veteran suicide rate because you might not be able to find that out. That might not be something that you can know in your area. It might also be that just one clinic in this large metro area is not necessarily going to lower the overall suicide rate for veterans. Maybe 20% is a bit aggressive. Maybe it's about the people that we serve or the people in our particular community or etc. Maybe it's not veterans who are served at the VA, etc. So really thinking about what can you do and what can you get access to, making sure that it's relevant, of course. And then the time bound piece um, is that, within 3 months, we will XYZ. Within a year, we will XYZ. That has to be relative to a particular point in time. Otherwise, you're just going to kind of keep doing this willy-nilly in a sense until you know this. So make sure that you're setting goals that make sense and then you're creating measures to see if it's working that are smart. So you've planned it, you're doing it, you're studying it, and then you're coming up with, oh, you know what? We're not reducing the rate. And we're discovering that this EBP is not really working that great, but we've got another one. Let's start testing that one. So you act, you just make the change. This isn't about sort of contemplating it, thinking, doing a year's worth of research to find out. This is fast acting. It's continuous, right? So your plan, do, study, act all day long, all week long, all month long, right? And this is something you actually do in your own brain all the time, but you don't necessarily stop and think about it. Like kind of like stages of change, changed everything about how I thought about myself. Um, this is happening all the time. You are planning, doing, studying, and acting all the time, even during this presentation. So then the next piece that I want to make sure you get, because I know we're coming in on to the end here, is there's a piece of CCBHC that people don't talk about a lot and that I feel like doesn't come up as much in CCBHC development as I think it should, or it's maybe a later thought that you have to think of early in order to make it work. I don't know. I'm gonna have to think that through. But your job as the CCBHC in your area is to make an entire behavioral health system in your service area. Doesn't mean you're providing absolutely everything. That's ridiculous, right? But it does mean you know everybody and you know who is providing everything. So you're doing outreach not only to communities that you would serve, but also to other organizations. What about folks who are doing food support? What about folks, food shelves, right? We sort of think, oh, case managers, they're thinking of that. No, we need to be thinking about that all around. What is the food supply in our area and how do people access it? And it's not that you're necessarily going to have all these goals to improve the behavioral health system in your area, but dang it, you better know everybody. Not even kidding. You've got care coordination agreements with folks. You might have designated collaborating organizations. Um, but there are so many folks that you can be doing outreach to, going to community meetings, community barbecues, there are coalitions about just about everything. Even in your tiny frontier and rural areas, there are groups of folks who care about something. Find out who they are. Get to those meetings. Send your staff. A lot of times people will sort of interview their staff and ask them, do you have any particular interests? Are there, and sometimes people say, well, I'm part of this walking group. Great. Can you talk to your walking group about the work that we do and get some information and outreach? So there are behavioral health associations, obviously, but all sorts of other kinds of associations. And I have a clinic, or had a clinic, well, whatever. It's still existing, an original demo clinic in a rural area in Minnesota, who they were already sort of a peer-focused organization. Well, they just multiplied that times 11. They had a peer respite across the street, so they were constantly making that part of what they did. They were over there all the time. They were finding out about other peer-driven programs in the area. And so they started to realize there was a whole behavioral health system in their rural area that was just based on peers and not necessarily certified peers, right? But folks who have been through recovery or are in recovery as well, or folks who have dealt with brain injuries and now they're all getting together for picnics to talk to each other about it. There's probably NAMI folks in your area. There's so many different groups that care about the people and serve the people you serve. And so it's so important that you're making those connections. Oh my gosh, how funny. Yesterday, I talked too fast and had so much time at the end. Today, I talked a lot and don't have as much at the end. So we just have a couple minutes here. So I was going to ask you to talk about what organizations in your service area have been interesting to you. But maybe if you've got a sec, throw it in the chat as we're finishing up here. Um, but to just, what are some organizations, again, that surprised you? That, like, wow, I didn't even know that there was, what is that, little brothers and sisters or whatever, that there's a huge thing going on at the local Y. I didn't even realize blankety blank. So hopefully there are some folks that you're meeting and finding that you never knew existed before. And boy, will they have a ton of information for you about how to increase access to care in your community. So make sure that you are getting out there, getting in there, outreach and engagement. Don't expect them to come to your open door. It's up to you to go out and find them. And you'll want to because they'll give you so much information. It'll be fantastic. So finally, we talked about that you start with the community needs assessment. Some of you are just starting with that now. It's a point in time sense here, like what's going on in my community right now. And it sets up baselines for all the work that you're going to do in this cycle. So that needs assessment is where you get started. Then from that, determining goals, developing programming, and then measuring whether you're reaching those goals and having a CQI team, committee, work group, whatever you want to call it, who is constantly plan, do, study, act, plan, do, study, act, and just getting everybody in your organization to be data informed. I think that's my new phrase. Data informed. They should be trauma informed and person and family centered, but also data informed. I've found that in a lot of clinics, you'd think clinicians don't really think about that stuff. They're dying for data. I would love to know of the progress that folks made that I was serving all along. It can be so helpful. All right. So that is the end of my training today. I hope that it got your minds cooking and thinking about all the stuff that you are wanting to accomplish with your needs assessment and CQI plans, and that you're preparing. You have one more training tomorrow, right, Matt?
Absolutely. Tomorrow's going to be a quick recap, but mostly kind of workshopping, discussion, other questions. So feel free to come with questions if you want to send them ahead of time. So if you have a complicated one, we can be prepared with a complicated answer for you. But we've got one more tomorrow and look forward to seeing everybody. A big thank you again, Miss Jane. You have done an excellent job and we very much appreciate your help with this.
Certainly. So much fun. Love being in Kansas. So you guys saw my contact information. Reach out. Tell me what you think, what you're working on. I'd love to hear about it.
And with that, we will see you all tomorrow. And thank you all for being here. And have a great one.
Bye, everyone.
Thanks. Thanks, everyone.